Okay, the
All right.
recording has started.
Thank you, Karen. All right, so good morning, everyone. I'm excited to be here with you today. For those of you who don't know me, my name's Brooke Hall, and I am the newest Senior Policy Advisor on the DFR team. And as I've stated in the last Rule Advisory Committee meeting, I will be taking over lead on this rulemaking from Cassie Susie, although Cassie will still be here joining us with her vast knowledge and helping me out along with Lisa Emerson. And I'll also be leading today's meeting. So since this is my first time kind of facilitating this meeting, I thought it would be a good idea to start with introductions. So can members of the RAC please unmute and introduce yourselves? That would be helpful. Thank you.
Hi, I'm Jennifer Baker with Providence Health Plan.
Hi, I'm Gary Holiday with Pacific Source Health Plans.
I'm Bennett Garner, a child, adolescent, and adult psychiatrist representing the Oregon Psychiatric Physicians Association.
I'm Laura Curtis. I'm here for Basic Rights Oregon.
Melissa Todd. I'm a psychologist in Eugene. I represent the Oregon Independent Mental Health Professionals, OIMHP.
And this is Chris Boneff with NAMI Oregon.
I'm Dan Toma, Senior Manager of Behavioral Health for Moda Health.
And I'm Antoinette Watching, Senior Regulatory Specialist for Cambia Health Solutions.
Hi, this is Tim Clement, Director of Legislative Development for the American Psychiatric Association.
Apologies for being late. This is Rachel Wiggins Emery.
All right, are there any other RAC members who would like to introduce themselves? Okay, so we have quite a few people from the DFR team on the line today. So can DFR staff, can you unmute and introduce yourself as well?
Good morning, everyone. This is Cassie Susie, Senior Policy Advisor.
Hi, this is Lisa Emerson, Senior Health Insurance Programs Analyst with DFR.
Hi, this is Tasha Sizemore. I'm the Life and Health Program Manager for the division.
This is Spencer Peacock, a Data Analyst for the division.
And this is Karen Winkle, the Rules Coordinator for the division.
Okay, any other DFR staff on the line that want to introduce themselves? All right. So we'll go ahead and get started with the agenda. I was trying to pull that up, Karen, but it doesn't look like I'm able to do that unless you guys can see it now. Can you see the agenda?
Yeah, we can.
Okay, yes. Perfect. Thank you. So the first thing on the agenda is an overview of the reporting conversations that we've been having with providers. As I think we said in the last RAC meeting, Tasha Sizemore and her team have been meeting with providers to discuss the reporting requirements that are in the bill, along with the template that was created to report. And we just wanted to provide you with an overview of those conversations and the comments that we've received during those conversations. So Tasha, go ahead.
Hi, everybody. Hopefully you can see me better. I realized my light in my office was still off, so apologies about that. First of all, I would like to thank all of the insurers that have met with us to date. I think we've hit all of our domestics at this point. The conversations were very productive, and it helped us better understand what the insurers could report and kind of what some of their concerns were. We also developed a strategy in some areas for specific benefits to look at, or specific ways to look at issues. So when I talk about benefits, I'm talking specifically about CPT codes. But so to kind of start off, as I mentioned, the meetings were very productive to help us understand the systems and kind of the issues facing insurers with reporting. So the first thing I'd like to cover is one change that we are proposing for the 2022 initial report. That change relates to reporting of the median maximum allowable reimbursement rate. So in discussions with insurers that really echoed what we heard during the RAC calls, it is clear that the insurers cannot produce an accurate report on the median maximum allowable reimbursement rate for the March 1st deadline. So what's going to end up happening is in the next couple of months, so for the March 1st report, we are going to hold off on the reporting of the median maximum allowable reimbursement rate, still require the insurers to report on the incurred claims amount rate. And then over the course of the next few months, possibly up to a year, we're going to work with insurers to get that median maximum allowable reimbursement rate to be to a reportable place. Though where it stands right now, and with some of the other work that I'm doing for the division, I don't want to report or have insurers report information that then feeds into a larger report that would be inaccurate or potentially weak. So hopefully in the next couple of months, we can help insurers find a way to report that median maximum allowable reimbursement rate on a better in a better way, or use what their systems have to get that reported. As I mentioned, that median maximum allowable reimbursement rate is not something that we can necessarily get for the first. So we're going to be discussing internally having a separate reporting date for that for 2022, or potentially, like I said, kind of depending on what it takes to get this to a reporting place, possibly just having the first report on the median maximum be in 2023. Any questions about the median maximum before I go on? Melissa.
I just wanted a clarification, because you said that they're going to be required to report on incurred claims rates, and we had, a point of contention and discussion had been on asking for reporting incurred claims rates as well as contracted rates. And so I'm just wondering where that went, and if that's tied in with the later reporting, if we're still going to be looking at that.
So yeah, we are still going to be looking at the incurred claims, and like I said, as available, the contracted rate, which is that median maximum allowable reimbursement rate. The insurer systems don't actually program that information in a way that is usable in this format, and that's something that the insurers brought up, and I feel very confident in my other work with the insurers that this is not something that we want them to report out on unless their systems can do it. So the incurred claims, we're going to do what we can with the incurred claims. And then once we get that median maximum allowable reimbursement rate / contract rate, we will go from there.
Okay, just one more question for clarification. Just can we apply the MMARR to the incurred claims rates? Is that going to be applied? Because we had talked about applying it to both incurred claims rates as well as the contracted data rates.
So we are definitely going to look at what is coming out of the incurred information and report back to the committee and the legislature on that. And I may need Spencer to kind of bail me out on this one. Apologies. But we're going to use what data we can from the incurred claims to understand like what's happening. It's just that contracted rate to get to the MAR just isn't going to be available. Spencer, help.
Yeah, no worries. Yeah, just to clarify, the plan would still be to collect the median maximum allowable reimbursement rate by incurred claims. It's just that provider contracted rate piece that it's just been determined there's too many unknowns, and we're more concerned with collecting bad data, and we feel it's worth taking the time and effort to work with industry and better understand the best way to approach that so that we do have valid, accurate, and useful information.
Thank you. I appreciate the clarification.
Thank you, Spencer. I don't know who else has their hand up. My apologies. Gary.
Hey, Tasha. I appreciate it. Just to clarify, so for on tabs 3 and 4, it would just be incurred claims information that we're submitting on that template?
Correct. Yes,
okay.
That's correct.
Okay, thank you for that. And I appreciate the additional clarification, Tasha.
Yes, yeah, no, absolutely. And for the insurers listening in on this call, I think that this is also kind of notice to you guys that we're going to be working with you to get accurate data on the contracted rates, whatever that may be. And there's a piece of the contracted rates piece that I'm going to hold until the end of my kind of conversation with you guys, because it relates to and leading into kind of network adequacy reporting. So I'm going to talk about that a little bit separately. So the second major thing that was decided as part of the conversation with insurers, and this is just really a clarification for the point of this committee, and just coming back to this committee with, if this is something we want to capture, we should build out and better understand reporting for this metric, but it relates specifically to substance use disorder and prescription drugs. So we're not going to do any reporting this year on anything prescription drug related because that is pulled from a different system, and once again, we just don't have that set up. So if there's something prescription drug related, let me know and we can work out reporting on that for 2023. And then the second piece of that, like I said, was substance use disorder. We're not going to have any kind of reporting specifically on substance use disorder this year for this March 1st report. Those CPT codes are different. Dan.
So I was just getting asked, does that mean we roll the substance use disorder in with the mental health?
Yeah.
Okay.
Yeah. So there are some very specific substance use disorder claims, like for testing, if you have certain substances in your system, and those are the ones that I'm holding back for this year. They're just, it does not make sense to include those because we have not had a conversation as a committee about what those mean and like how to have value in the reporting of those. So if that's something that the committee is interested in, definitely willing to talk to folks about it, just not for this first report. And then the third kind of major piece that in conversations with insurers, and this really, I think we spoke with every insurer about this, but in trying to understand how claims are being paid and kind of where things may be not functioning correctly in line with the laws, we initially looked at only having insurers report out on CPT codes. And in talking with insurers, and in, once again, other work that I'm doing for the division, there is a diagnostic code component. And so in talking with insurers and in speaking with insurers, we're expanding what we're asking for just slightly as part of the reporting to get a better understanding of what actually is happening with CPT codes. or with specific codes. So what this means is that for the purposes of clarifying our reporting, we are going to ask insurers if there's like a diagnostic code or also a provider code that is associated with a particular line. And in order to get the best data, we're going on a line-by-line basis. This is going to be a lot more data. We recognize that. We had a lot of conversations with insurers about scoping the data and really getting what we wanted from each insurer. And it became clear through conversations that just focusing on the CPT code would not be the right answer. We may see that there are CPT codes not being paid at a certain rate, but we may not know why. So getting that underlying diagnosis code information is going to be helpful. Any questions on that? Gary.
Hey, so you're gonna issue revised guidance or something to clear? Do we know when that might happen?
So we'll talk about that in just a second.
Oh, sorry. I'll slow
No, you're fine. Fine. Oh no. So the other piece of that is just making clear that we are going to, I think Spencer, correct, that we're separating versus in versus out of network, and there are any carriers that use different tiering that we've kind of talked to them and talked to some carriers about that. So if they have a preferred in network, non-preferred in network, and then out of network, like making sure we capture all of those nuances. So anything that I'm missing, Spencer?
Nothing specific that I can think of. You know, I'm just going to echo, we really appreciate the conversations, and there definitely is additional, more detailed guidance that we need to provide, and we're definitely working on that. And as Tasha mentioned, I think she's going to speak to that a bit more.
Thanks, Spencer. Bennett?
Yeah, just so am I understanding you to say that you were thinking the amount being paid for, say, a therapy session will vary with the diagnosis? Is that what you're...
Potentially, okay. Yes. Or that there may be other kind of underlying things that we need to look at with like prior authorization based on diagnosis codes, stuff like that. So really digging into how the diagnosis code, provider type, and CPT code all kind of interplay.
Okay. My immediate reaction is I can see where the number of sessions might vary with the diagnosis. Hard for me to see why the amount paid per session would vary for the diagnosis, because the RVU isn't going to change.
Yeah, no, and this is why in talking with insurers and understanding that there may be something there, we decided that it was worth at least looking at and better understanding for the first year, because the alternative is that we ignore it and there could be something there and it sets us back. So I know that.
Thank you.
Yeah, no, and I know that we talked to many insurers trying to pick the right one, and like I said, we just decided to go with all of them because we want all the information. Any other questions? Okay. Oh, somebody, Antoinette.
Yeah, quick question. Are we going to get the chance to have a sort of like an advanced preview of those CPT codes?
Yes, so we're going to talk about CPT codes and provider types, I think, here in just a minute, right, Brooke? Yeah,
that's correct. It's next up on the agenda. And I apologize, we did send you the list of CPT codes that we'll be talking about late last night. My intention was to get those to you earlier in the week, but it's been a very busy week. So you should have them in your email box along with the agenda.
Okay, great. Thank you.
Thank you, Brooke. And then the before we talk about the back to the contracted rate piece, I do want to talk about the timing of this report. So in conversations and recognizing that we are in the middle of an Omicron surge, which is, I can't even keep track of how many surges we've been in now. We would like, as a division, to discuss it with this group, postponing the date of the report to either March 15th or April 1st, with a preference on April 1st, to give carriers and the division, frankly, time to look over the data and breathe, and you know, have a chance to like put everything together. There's going to be a big caveat kind of next around, you know, why we're looking at doing this, and we're going to talk about contracted rates a little bit. But is there any concern from this group about holding the reporting date and pushing it back for 2022 only to April 1st? Jen?
We would very much appreciate the April 1st deadline, especially given some of the updates that you provided today. We appreciate you working with us and understanding better how our systems work. So April 1 would be a huge relief for many of us. Thank you.
Yeah. Gary?
Same thing as Jennifer. April 1st is our preference, and we greatly appreciate it. Gives a little more time, especially with some of these changes coming through. Thank you.
Okay. So I don't hear anything that really is against April 1st, and insurers, I'm being really nice right now, but you're probably not going to like what I have to say next. So apologies. There's kind of a double-edged sword to this. So yes, we will hold the report until April 1st. And Spencer and I will work on getting that out to you. I'm working on getting folks hired so they can review the report, and having those folks trained up. I do want to talk about what else we learned from the contracted rate discussion. And I apologize if I'm blowing up the agenda. This just kind of fit naturally. So in talking with the insurers about the system limitations and looking at the contracted rates, it became clear that there may be a tie-in with the inability to access this information from their system to what is actually being reported out and claimed in network adequacy. So if their systems are showing that there are contracts in there that are older, which I understand, talking to all insurers, between the Reproductive Health Equity Act and this one, there are claim system limitations there, and I don't want to make light of that, but like there's a tie-in here, very clear tie-in, that there may be stuff being reported out in those contracted, based on what's in the system for contracted rates, that isn't actually network providers anymore. And we heard this from, I think, almost all but one insurer. And so, you know, in talking with the insurers and in talking internally, it became clear, you know, first of all, yes, we absolutely need to give insurers more time to dig into like what is in their system in terms of, you know, providers with contracts and, you know, what their limitations are in getting the contracted rate information for us. But the second piece is, if there's information hanging on out there in the claim system that is saying that there's a provider or contract in place and that's being reported on or being posted as part of network adequacy, that means we can't trust some of the network adequacy data that is coming out of, you know, kind of the next part of the report. So in working with this, that's going to kind of be the next piece as we're talking with insurers about their contracted rates. It's really understanding how, you know, there may be information kind of trapped in their system that may be reporting out incorrectly in other ways, and fixing that kind of all as one. And like I said, this may be an issue impacting all insurers. I think there was just one that we didn't talk, like that it wasn't the same level of issue. But it was because their model is significantly different. So any questions on kind of the network, like what we found in talking with the insurers on the contracted piece? And I know.
Hey, Josh. Oh,
Yeah.
sorry.
No, go ahead.
So-
Go ahead.
So what's the next step on that one? I mean, can you give us just a high level, what you envision the division doing next? Is it another meeting? What is it?
So I have a meeting to talk with Alex, and I think he might be on this call, and I might scare him just a little bit. But we have a meeting to discuss network adequacy reporting for 2022 anyway, and then I was also going to tie this in. So we're going to have to talk with insurers to, first of all, figure out a timeline to get the contracted rates information pulled from your system, and then we're going to have to do some sort of, and I don't know what this is going to look like. This is going to depend on staffing level and what we learn from insurers and kind of how big a lift this is. But it may result in some kind of desk exam to look at like how that information is functioning and make sure that there's not incorrect information feeding up through the rest of the system. In the next, probably, like I said, I'm meeting with Alex tomorrow to talk with him about network adequacy. Generally, when we met internally and talked yesterday, we did talk about the potential for an exam or just like, capturing this through network adequacy reporting in other ways. And I did want to be very transparent with the committee, though, that this was something we found, and this is going to sort of impact the next kind of steps as we move along.
Great. No, we appreciate it. And like I said, I'm trying to imagine how prompt this is going to be if, we're going to be jumping on this in April or is it going to be more in summer?
It's not going to be February 1st. I will tell you that. Like, we're going to have time. Like, I need to talk to Alex and figure out like what the appropriate like next step is and how we want to, I guess, like schedule this out with insurers. And depending on the amount of time it takes, like I said, every insurer kind of has this at a different level, or every insurer's claim system is different. So this may take kind of like a multifaceted approach.
Okay, thank you.
Yeah. Any other questions? Okay. Did I miss anything, DFR team?
I think you covered everything, unless there's something I forgot or Tasha forgot, Spencer.
Hey, Tasha, it's Gary. And so this report that we're going to push till April 1st, is that all the elements of that report? The NQTL summaries, all of that? Okay, it's a single package.
Yeah.
Okay, cool.
All right, so that wraps up the reporting conversation section of the agenda. The next part of the agenda was a discussion of the CPT code list, which, like I mentioned before, we did send out that list via email late last night. But Tasha, if you want to go ahead and kind of give an overview of the list and any conversation that ensues.
Yeah, can I have like Karen or somebody share that? I can't get my screen to share today. Apologies, guys.
Let me get on that.
Thank you, Karen. Also, just talk generally while she does. So my goal was to start with a small amount of CPT codes that were codes that I have directly talked to stakeholders about. Melissa, I don't think, Bennett, you've been on those meetings, but I focused on the 90837 and 838 type codes and tried to find codes that mirrored in some way from the E&M codes to, so evaluation and management codes, to make sure that I wasn't like reaching out into non-paralleled areas, that I needed codes that I could easily track. So like I said, for this first year, I didn't go through all of the CPT codes for psychology, but I did hit a number of them. Karen's getting it for us.
Okay.
Thank you. So I am working off of the 2020 CPT coding book. And I did just recently get the 2022 codes. I think they're all the same. But if there's anything that doesn't make sense, let me know. So there are some codes that are psychiatric services that are reported on E&M codes. And so I did capture those as something that would need to be reported under the mental health parity component as potentially well as the med surge. And then I also looked at codes that like supplemented other codes. So the interactive complexity code is one that I was very interested in. So the 90785 code. This one I think is very interesting for the division because we are also working on DEI. So if there are any like communication factors that would play into that, this one may help us kind of report out on that. So that I think might be the only one that may catch people off guard. Otherwise, I just picked diagnostic evaluation codes. And then, as I said, the 9083 series of codes for psychology and psychiatry codes. I also picked crisis level codes so that we could evaluate. In my conversations with providers over the years on this issue, there is a component of this that is kind of like emergency or critical care related, and like a provider having to step in and take care of a situation immediately and making sure that there's capturing of that. So I did capture hypnotherapy and some other codes just in case, and electroconvulsive therapies on the list. I have a love-hate relationship with the idea of putting that in there, but wanted to have a conversation about it in case it was important. Okay, Karen, if you want to scroll down, just
down or up?
Down.
Down, okay.
Up. So we get through all of the psychiatric and mental health codes, and then we just get to the general medical surgical codes, which are categorized in time count just a little bit different. So they have 30, 45, and 60-minute codes that operate just a little bit differently, but I figured those would be the best to capture. The medical surgical side. And then is there anything on down, Karen? I don't think so.
No.
Yep. Okay.
That's it.
Yeah. Are there any codes, Bennett? Bennett?
Under the general medical code, I didn't see 99213, which I would think is used fairly frequently.
99213, we can definitely add that one.
There are lower codes too. I don't know how frequently they're used, and I don't know that they'd be very comparable to psychiatric codes, but I think that's something that would be used in both settings fairly frequently.
Okay. Anything else, Bennett?
No, but I'm trying to look at this quickly because
we'll come back.
Yep.
Come back for sure. Melissa.
Yeah, just echoing Bennett on the at the very end of the list. Yeah, right. What we're looking at. Some of the lower codes would include 99213, 99212, 99211. So it goes all the way down to 99211. And again, this is sort of where we're looking at incurred claims versus contracted rates data, might tease some things out. It may be true that some of the lower codes are used less frequently or maybe infrequently, which is also true of some of the psychotherapy office visit codes. But when we look at the comparisons, we're looking for those trends. One of the things that OIMHP is really advocating for looking for is sort of trends in how medical is paid as duration of office visits increases versus how is behavioral health paid. And so that's where we think looking at the lower codes just for looking at those trends would be useful. So it does go all the way down to 99211 on the established patient visits. And then again, what we really, it is difficult figuring out what to compare and what's going to give us the most meaningful information. And so that's why we've really focused on office visit codes that are time-based, because both behavioral health and medical surgical do see patients in the office and in a time-based manner.
Thank you, Melissa. Dan.
Thanks. Yeah. So I find this list a bit confusing. So if the E&M seem really straightforward to me, 99202 through 99215, just that whole set of codes. What is confusing to me about this list, the legislation calls for us to report on each time-based office visit code. And there are a lot of codes on here that are either not time-based or not office visits. And so this list of codes seems to extend far beyond the scope of the legislation, and wondering if maybe we could pare it back to more being within the scope of the legislation.
Yeah, no, and I was just basically trying to find stuff that was comparative and make sure that I was broad enough. So like I said, there are some codes on here that probably don't need to be reported, at least not for this first year. So if it's okay with the committee, we can, with the exception of the interactive complexity code, which is one code I do want to keep, we can maybe pair some of the like 90885 codes and remove those for this reporting year. Any concerns with that? Bennett, is your hand still up from earlier, or do you have something else?
No, sorry, I forgot to take it down. I'll do that now.
It's fine. Jen Baker.
So we would agree with Dan that we need to keep it to the boundaries of the statute on the codes, but we'd also recommend that the DFR look at the federal self-compliance guide appendix to see if that is a useful resource. But definitely agree on paring down to match the statute.
Okay. Rachel Emery.
Hi, don't necessarily disagree with the notion of paring down. I just haven't had a chance to run this by my folks. So if there is an opportunity to weigh in, if we feel differently once my experts have taken a look, I'd really appreciate it.
For sure. And like I said, there were just some that I threw in there because it was in the psychiatric code portion and may be something that is worth conversation. And once again, the interactive complexity code I'm keeping in there for just broader DFR purposes as well. Okay, so I will take off some of the codes, Rachel, and other stakeholders. If there's any codes that you feel very strongly about from kind of the miscellaneous section that covers hypnotherapy and stuff like that, let me know. Happy to capture those. Any other, Dan?
Yeah, just one more comment. In terms of time-based office visits, there is another set of codes that is worth looking at, which is the health behavior intervention codes.
Okay.
No, I have them written down somewhere. I have them written down right, maybe here. 96156 through 96171. Those are, in my view, would fit within the scope of the legislation.
Okay, I will look at those. Oh, CPT coding book, come here. Okay, Antoinette.
Yeah, so when would you like our feedback on the codes by? I know we're on a time crunch in a way.
Monday.
Okay.
Yeah,
Thank
I will
you.
add I will add the health behavioral codes that Dan mentioned, and then mark which ones that I feel comfortable taking off that like are not time-based visits. Mark.
Yeah, thanks. So earlier in the call, you mentioned incorporating diagnoses into this analysis with the incurred claims and the CPT codes. Is that still something that we're aiming at doing? And if so, what are those diagnosis codes going to be?
At this point, I think we're just going to have, great question. I think at this point, we're just going to have insurers report all of those claim lines regardless of diagnosis code so that we can understand like what diagnosis codes are out there to get a better get a better feeling on that. Same with provider types. If that is a key component of the claim system operation, we need to understand how that factors in.
So
Any other, yeah, Dan.
yes, sir. Does that mean you're requesting? So I had envisioned this report as being aggregate. So we're reporting the median maximum allowable for each code and provider type. But if we're getting into diagnosis, and if you're requesting all that information, that would sound like you're looking for claim level detail for everything, which probably gets us into the hundreds, probably hundreds of thousands to millions of lines of data. And so I'm just curious about how that's envisioned to work.
Spencer, we haven't really talked about that, I guess.
Well, yeah, Tasha, I think we need to chat a bit more about how we actually wanted to have the diagnosis codes play into this. So maybe we could chat about that and get back to the group.
Yeah, no, for sure. I think to kind of keep with the theme, maybe just have the tally of diagnosis codes and not report on like all the claims, but let Spencer and I circle on that. Because this is, once again, every carrier has developed their own claim system on this. So we will talk.
Thanks.
Yeah, no, great question. Any other questions? Okay. I'm done.
Thanks, Tasha. And again, we understand that you didn't get a lot of time with these codes or this list before the RAC. So please take some time to review it yourself or with your team and provide any feedback that you have to myself or Tasha or Cassie by Monday, if possible. All right, so if there's nothing else on the CPT codes, I believe the next section of the agenda is to continue the conversation that we ended on during the last RAC meeting, which was regarding Section 6 of the bill and network adequacy. And we thought it would be a good idea to start off this conversation with an overview of how DCBS currently evaluates network adequacy, which again means, Tasha, you're up to kind of give that overview. So if you want to go ahead.
Yeah, no, for sure. I was just opening up my CPT coding book for fun and games to continue in that realm. I wish I would have done like coding in college or something. I don't know. I don't know if they do those classes. Anyway, so wanted to talk a little bit about network adequacy. And like I said, I talked a little bit about what we found talking with insurers, and that plays into this conversation. So currently how network adequacy is evaluated is insurers submit a annual report on March 31st that describe that insurers network or networking behavior and processes as outlined in our rule. Our rule doesn't have a whole lot of specific like there has to be X number of providers. It doesn't go into that. It's really the carriers evaluating their own network against kind of national standards. And we've, as CMS Other agencies have kind of changed national standards. We have, I think in 2019, updated our process to make sure that we aligned with that. Between 2017 and 2020, we allowed insurers to submit a network adequacy report on their kind of own reporting, in their own reporting format. And in 2020, as I mentioned, there was some kind of reporting and access changes around NCQA and some of the evaluations that were available on networks. We updated the rules, and at that time, the compliance team took a little bit of a look at the reports that insurers had been sending in and did a deep dive. And what we found was there was no way that first year in 2020 that we did a deep dive of the reports to do an apples to apples comparison of networks. So for the first time in 2021, we updated our reporting guidelines and set insurers on a path to report kind of all on the same template and all kind of focused on the same general questions that we receive about network adequacy. So the overall reporting template really improved the quality of the reports for 2021. We learned a lot about networks that we didn't fully understand. We also asked some diversity, equity, and inclusion questions to start that conversation. You know, in looking at how insurers reported and how we could best evaluate, we are planning, I think, and once again, I have a meeting with Alex tomorrow, and some of the kind of information that we found out doing RIA and this work may slightly adjust this. But for the 2022 report, we're looking at having the exact same reporting template with just a couple of adjustments that have already been kind of communicated to the insurers since December. And those adjustments are to mostly better align what we're asking for with how the insurer system captures it. So for example, as a consumer of insurance, I typically think of wait time as the time that it takes for me to get an appointment to see a doctor. Insurers calculate this as appointment availability, and they have that's kind of how their system tracks it. So there were issues like that, you know, in talking with the insurers and seeing how insurers track their system for the 2022 report, we made some clarifications about like, no, we're not looking for wait time. I don't care, you know, how long I have to wait in my provider's office because somebody could be in crisis or whatever. So there's not, like, that's not necessarily on the insurer. But the appointment availability piece may be an accurate comparison for us to look at. So there were those minor types of changes. And so that's the annual network adequacy report. And then I think that this topic also doesn't just stop with the network adequacy report, but also is meant to encompass the other things that the division performs to determine if there are network adequacy issues out there. And in the last year, there are several things that we have started to work with insurers on, and it's actually been longer than that now. Probably 18 months plus. Pandemic time all runs together. But there are some areas where we have started to really ask insurers and get into, you know, how long is it taking to get an appointment with a particular provider, and trying to understand. And oftentimes this is a joint effort between my team on the compliance side and the advocates to really understand what is the cause of the network inadequacy. So you know, we also, it's not just reporting, we also work on that level. Now, earlier I mentioned that, in talking with the insurers and learning about how their claim system works and how all that feeds up, we do have concerns that there are things that are reporting from the claim system that may be in some way skewing numbers or may not be telling the whole story because of how the contracts might be, in some cases, integrated into their system. So as I talk that out with Alex, that may change how we ask insurers to report just a little bit this year so that we can better understand that mechanism. And then just a couple other network adequacy pieces that I want to mention that the division participates in. So we are also engaged in like primary care spending reports and other stuff that ensures that there's like adequate money going toward primary care. Doesn't necessarily help in this situation, but I did want to bring it up. And then insurers are also required to, at binder filing in the individual and small group market, submit a provider list that is going to be associated with those. That provider list is a point in time list. It changes. There are limitations with how we can use it and limitations on how we talk about using it internally. But over time, we have increased what insurers have to report on that template. Initially, they could just list the provider names. Now we're requiring NPIs and other information to be listed. And I can't remember, I think that was the first year we required that was for the 2020 binders. And that information helps us when issues and complaints come up. We can have Spencer or other people take those NPIs and compare them against databases that we have access to kind of understand if there may be an issue happening with in a particular area. Not 100% by any means. There's a whole bunch of analysis that goes into it. But this is how we have traditionally handled network adequacy. And like I said, we're learning all kinds of new things because of reproductive health equity and now House Bill 3046 reporting. So this is an ever evolving topic for me.
And sort of transitioning into the bill and talking about what is required within House Bill 3046. One of the pieces that it does require the department to clarify and rule is what the adequate number and the geographic distribution of professional counselors, licensed marriage and family therapists, licensed clinical social workers, psychologists, and psychiatrists who are accepting new patients. And so want to hear if there are any thoughts, if there was conversation around this during the legislative session, sort of some of my initial thoughts in terms of like the adequate number. In our conversation about contracted rates, it likely kind of thinking of scoping that out to an adequate number of providers who are currently active and not just having the contract with the insurer, making sure that it's specific to providers who are accepting patients and do have kind of a more active more activity than I guess like a contract that's been on the books for 15 years and no patients have been accepted. But would love to hear from RAC members about thoughts on that. And then also geographic distribution. Historically, when we do geographic distribution reporting, it is around, I think, the geographic kind of markets that we separate the state into. But would like to hear like if there's feedback on looking at that differently or if that seems sufficient for this evaluation.
I would also like to note that CMS and the notice of benefit and payment parameters also is keying in on like wait time issues there, and also the like availability of provider within the time and distance standard, which is what many insurers currently use to calculate. So just knowing that, like making sure that you guys were aware of that.
Rachel.
Yeah, I'm happy to give sort of the coalition perspective on this. We really wanted this to be a conversation that happened with the experts, with the recognition that networks now are probably not adequate. We hear all the stories that people experience, the frustrations trying to access timely care. So anything we didn't think it was appropriate for the coalition to have a discussion around number and specific geography, because we're not the experts in what it looks like for, timely access to care, other than we know that like folks need care when they need it. I do know that I don't think we have any issue with sort of the breakdown of the geographical, the markets that you all use. I think we wanted to be really clear that access to care can look different for folks based on where they are, and it isn't necessarily fair to expect that carriers in Portland have the same number of providers as carriers in Grants Pass. That's entirely different populations. So I hope that's helpful. We didn't have a ton of specifics. We just really wanted to make sure that we had a thorough conversation with you all, recognizing that sort of the current requirements for network adequacy aren't getting the job done.
Thank you. That's helpful. Chris.
Yeah, so I just want to piggyback on that. From NAMI's perspective, however, the verbiage is in the insurance verbiage to actually bring this about as an analysis, but the predictor is between the time I reach out for help and my initial appointment and the time between my initial appointment and engaging in services are all predictors of whether or not I'm going to show up for my appointment and engage in care. And the longer you take between the time you reach out, the less likely I'm going to do. So if you're 14 days out, it's barely a 50-50 proposition that I'll show up. So, we didn't come up with a day standard, and other things like Rachel said. If you look down south, California has come up with a firm standard now, 10 days. I don't know where that comes from and whether that's evidence shows that I'm likely to show up, but that's the genesis of, from our perspective, as a process measure, that's an important measure. And it sounds like that's the terminology you're using for that is appointment availability. But it really is that time between reaching out for help, initial appointment and ongoing engagement that is the most valuable data points in terms of predicting whether or not people are getting care and engaging in care.
All right, we'll move on to Bennett and then we'll go to Rachel.
Yeah, I would suggest that the data be disaggregated. So for example, one clear distinction is availability for psychiatric, meaning, medical services versus therapy services. Another is language competency or cultural competency. Another is it's hard to figure out how to slice and dice this, but there's clearly issues between substance use disorders availability, mental health availability, comorbid availability, issues with developmental disabilities. The problem is that's a whole rabbit hole in terms of eating disorders and borderline. You got to figure out where you stop that, but I think some level of disaggregation is important. And the other thing that I would suggest thinking about is standards for emergency versus urgent versus routine availability.
Thank you. Rachel?
Yeah, one thing I forgot to mention, and building off of Bennett's comments, that we were also really intentional to include that it's not just access to care, it's access to specific types of care. And it's not included in the list, and I know it's been in our comments, but I made a promise to someone during the legislative process and didn't want to do yet another amendment. If in the rules we could call out specifically services for LGBTQIA folks, the intention was to include them all along. They were unfortunately left out on our list, and by the time we realized that, didn't want to have yet another amendment that we needed to negotiate in the last minute. So just wanted to add that. Thank you.
Jen.
Yeah, I just want to follow up on what Rachel just said. And I think that if we start calling out specific communities, and while we are targeted at supporting the LGBTQ plus community, we don't want to necessarily create a slippery slope where we're going to have multiple advocates coming at us and saying, well, now we want separate for our group or this group. But, I haven't had time to really discuss that internally with our folks. A couple of thoughts I want to just bring up in network adequacy. In general, like I recognize that we want to make sure that insurers have adequate networks, but we can't create an adequate network necessarily if there aren't enough providers that exist. So we have to take that into consideration. I think Rachel had mentioned that before. Geography is going to play a role in that. You're just not going to have the same amount of providers in Grants Pass that you're going to have in the Portland metro area, but also providers. There's a couple of things on the provider end that are not required. They're not, we're not keeping track of how many providers refuse to contract after we initiate those discussions, or they refuse to take what is considered the standard rate in that particular area. There's also providers who don't update their data enough. I mean, they're not required to let us know the availability or their whether or not they're accepting new patients. There's so much data that we don't get, that we have to get from providers in order to give you that data from our perspective. And so we can only give you what we have when you're looking at our networks. And if we don't have that data from providers and they're not required to provide it in a timely manner, then it's not giving you an accurate reflection of what our networks actually look like or what we want our networks to look like. So keep that in mind when we're creating these new requirements.
All right, Melissa?
Yeah, a few thoughts. I wanted to just kind of bring up the issue of looking at out-of-network utilization as a measure of network adequacy. This is something that the Milliman reports did, as well as a nice report that came out of the University of Pennsylvania. I think I had sent you links to that pretty early on in an email. And so, what they found was that out-of-network utilization was much higher for behavioral health than it was for medical, and that in and of itself was a measure. And as we've been discussing, if somebody can't find someone in their network, a lot of people are just going to give up and they're not going to get care. But you've got people who are going out of network. They must be the really motivated people, or the people who are really in need, or maybe the people who have the resources. But if we're seeing much higher rates of out-of-network utilization in a behavioral health network versus a medical network from the same insurer, it just seems like there's something to look at there. So that we think is important. And then, this is why we've been advocating for transparency and trying to pull as much data as possible, because when we look at the contracted rates, for instance, if you've got a contract that is 15 years old and there's a provider who's just not active in the network at all, and they're being counted as part of the network, we've been referring to them as ghost providers. We want to figure out, how to get them out so that we can get a more accurate representation of what's on the network. And so if we're looking at incurred claims data, we're looking at contracted rates data, we're hoping that that'll come out. And also just another thing that we've been seeing, and I think came out of some of the SB 860 report, is just how often contracts are updated for medical versus behavioral health. If contracts aren't updated often, then that's where we might find those ghost providers, those people who aren't actually active, maybe people who moved or retired or died that are still somehow on the network. And so if there's more activity in terms of updating contracts and maybe requiring providers to do something such as accept a new contract or accept new rates, then that can be a way of showing whether that provider's active. And then to kind of present a different perspective to what Jennifer said, if there are providers who, for instance, are refusing to sign a contract or refusing to, or who just aren't active and not taking new patients or not billing, why is that happening? Is that particular insurer having a hard time getting providers to join their network a hard time getting providers on their network to actually accept new patients. And, we've kind of contended all along that looking at reimbursement as well as utilization review practices gets at that, because providers tend to avoid taking new patients on, lower paying panels, or if they feel like a particular insurer has been particularly aggressive in utilization review, they might be hesitant. The example that I often use is you take a patient who is has a pretty severe and persistent mental illness. The expectation is that you're going to be probably seeing that person for quite a while. You might be handling some crises. You might sometimes have to see them, more than once in 1 week. And if you've got an insurer who, aggressively sort of reviews you when you end up having to do those sorts of things, then, you're going to be a little bit hesitant to want to take another patient from that insurer if you feel like you're going to be pressured in some way or another. So, there are also those arguments and those perspectives from providers. If a provider is not working with an insurer, is not getting on their network, is not taking new patients, why is that happening? And we're hoping that the more data we obtain and the more transparent we are about that, we'll start to get at that information.
Bennett?
I forgot to mention this when I was speaking before, but I also think we need to think about where telemedicine fits into this whole network adequacy, and I'm particularly sensitive to this because I practiced in Astoria for 9 years, and to some degree, you can solve the problem in a place like Burns with telemedicine, and yet there's a virtue in having somebody on the ground in that community who knows that community very well and can for example, in child psychiatry, interface with the schools and the DHS or whatever that somebody living in Portland's not going to know. So I don't know how to balance those two things, but I really do think we ought to be overt about where telemedicine fits in the network adequacy, particularly in rural areas.
Dan?
Just a couple of thoughts, almost free association here, because this is a really challenging subject. One is, in thinking about network adequacy, a useful reference is NCQA standards. And NCQA makes a distinction between availability and access. And they define the two in a way that always confuses me. And I feel like I 50-50 in my chances of saying getting which one is which correctly. But one is, do you have providers and what's their geographic distribution, the time and distance standards? I think that's availability. And then access is, how long does it take to get an appointment? Do you wait 3 days, 14 days, 30 days to get an appointment with a particular provider type? And those are both useful metrics. Availability, that geographic distribution, that's easy to measure. Access is particularly difficult to measure, time to appointment, especially for carriers, which most of us are, that don't do our own scheduling and don't require a patient to call us to say, I need a provider, blah, 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 blah. So the best that we're able to do really is to measure that indirectly through, the best that we, at least at Motive, been able to do is through member surveys. And there is, all the issues that go with surveys attendant to that, including that granularity. You just can't get down to granularity when you're getting your data that way. So that's a challenge in measuring that. I think Melissa's point about in-network versus out-of-network utilization it seems like that could offer a pretty good proxy for network adequacy and people's ability to get the provider that they want, that fits their needs in a reasonable period of time. I think we also have to acknowledge that in that are baseline and starting out with that is that disparity that Melissa mentioned between, out-of-network utilization is a lot higher for behavioral health. It's also a lot higher for like alt care, chiropractic, and those kinds of things. So there's these differences that are baked into our current situation that I think we need to acknowledge. But I think as we look at network adequacy, that can be a useful proxy measure.
Thanks, Dan. And I actually have to hop off to another meeting, but I will pass it over to Brooke to continue the conversation on network adequacy. I think we would love to, if you have written comments on this, to send those in. I know this is an important piece, and I know we've mostly been talking about adequate number and geographic distribution. There's also this sub E that is other groups specified by the department in rule. So we'd love to hear about that. If I know we've heard about the LGBTQI plus community, but if there are others that we should be considering, please let us know. And I will pass it to Brooke, but to kind of lead the rest of the conversation. And I will see you all at our next meeting.
Thanks, Cassie. So just, I want to do a time check. It's about 10:15 right now. We do still have one last section to cover before the end of the meeting. So I know this is a very important topic and I don't want to cut it short, but I think we're going to end the network adequacy conversation with Tim and then with Jennifer, and any written comments that anybody has, you can submit to Cassie or myself, and we'll review those. And if we need to continue at the next RAC meeting, we can do that. So go ahead, Tim.
Sure, and I'll be brief. I know we're running over time here. So I'm not sure if you have the authority to do this, but just several of the comments that both from industry and the advocate side that I've heard is one thing that's important is network performance and the actual ability to access providers within the network, even if they're listed in network. One approach that I know some folks have taken in other states is determining the percentage of providers listed in the network that have filed 0 claims within the previous 6 months, or say 1 to 3 claims within the previous 6 months. And then anyone who's beyond that is probably a real participant in the network. And some of I'm just totally blanking on the insurance departments that have done this, but found some somewhat troubling trends in that, with the percentages of 0 claims in the previous 6 months being kind of high. So if that's something you can do, that's just one way to think about it. That gets at that ghost network issue. If that's not, if you don't have the authority to do that, then I understand that you can't do it. But just a thought to put that out there.
Thanks, Tim. And Jennifer, I know you had your hand up. Did you have a comment?
Yeah, I'll be real brief. I just wanted to get back to what Melissa was saying, and the analysis that she's asking for is already done via the NQTL reporting. We supply out-of-network comparative analysis as required by Parity in our NQTL work. So we're already monitoring it and measuring it as it's required by Parity in the NQTL analysis. And we ask that you take a look at our NQTL comparative analysis reporting via the 3046 and decide if more regulations are needed before we go down that road. But the other thing, in response to some of what she said about network adequacy, I've worked for multiple carriers, and I realize, she says if it's asking why on a certain provider or a certain insurer, I mean, it's a problem with all the insurers. It's not insurer necessarily specific. And I agree with what Dan said on, we can't require those of us that don't require our patients or members to call in and schedule. There's just information we can't get unless a provider gives it to us, and they're required to give it to us in a timely manner. And then, what our network analysts have noticed is that, the more, and it's a difficult discussion, but we have to recognize the more you pay, right, above and beyond what is the standard rate, the fewer patients we see our providers accepting. And so that's also creating problems within the network. It is not, you cannot put the entire onus of provider adequacy or, being able to get a provider on the backs of insurers. It's just impossible. The providers have to come to the table too.
All right. Thanks, Jennifer. Melissa, go ahead.
again, I'll try to be brief, but just with all due respect, what we see is that not every insurer has the same level of problem with network adequacy. It's pretty well known that there are a few that have more of a problem with that, and we tend to see trends of lower reimbursement or stagnant reimbursement rates as combined with high levels of aggressive utilization review from some of the same insurers. And OIMHP conducted a survey with providers some odd years ago. I can't quite remember the year. It might have been 2017, where we had just asked specifically about some of the major insurers in Oregon. Are you thinking of leaving a panel, and if so, which ones, and what were your reasons? And really what we found was that for certain insurers, there were a high number of people who either had left or were thinking of leaving, and that their top two reasons were low or stagnant reimbursement rates and aggressive utilization review. So, that is a trend that we were able to measure with that survey.
Thanks, Melissa. And again, I know this is a very interesting topic area. We could probably spend all day talking about network adequacy. And if there are additional comments, either on the sections that we've covered today around network adequacy, or the piece that we didn't get to, which is that subsection E on others individuals we should be considering, please provide those in written comments to either myself, to Karen, or to Cassie. All right, so we only have about 10 minutes left, but we do have one section of the bill that we haven't discussed yet, and that is section 8. I do want to give some time to that section, which deals with utilization reviews or other clinical reviews and the criteria used to determine those. So when developing rules on this section, is there anything specific that DFR needs to consider?
Is that in addition to the comments we've already submitted?
Correct. I know there has been some comments that have been submitted that really deal with the ability to allow third-party providers in utilization and criteria reviews. Those are the ones that I've seen.
Okay, so this is NAMI Oregon. We'll resend some of our comments, but the tricky issue is the legislation is very clear in that when it comes to level of placement, those are not third-party proprietary pieces. So there's a distinction there, and it does get tricky in that some of the third-party criteria could be used to deny medical necessity when the actual evidence-based instruments say somebody needs a certain level of care, and making sure that the rules are absolutely clear that when it comes that a third-party criteria under, I think it's 8C something or other, isn't a backdoor around to denial for care.
Yeah, and thank you for that distinction. Dan?
So also speaking to the level of care issue, which it looks like is 5AB, the concern that I have, when the early on in the legislation, the discussions around the legislation, there was a psychiatrist who had led a system of care in another state, and I don't remember the details. I tried to find his testimony, I couldn't, but he said that the whole system used the locus and CalLocus, and that worked well. And what my concern about this is that somehow in the legislation making, the CCOs were left out of the requirement to that's in specifically 5AB to use that most recent version of these. And so, the providers of residential services, as far as I know, have been left out of this conversation already. And so I'm concerned about a situation where we may end up with commercial insurers on 1/1/23 requiring information from the providers that gives us the information to complete the locus or calocus, which is pretty extensive and may not be the same assessment that the providers are doing, and the providers not necessarily being prepared to do that. To me, the simplest way to get the information would be to tell the providers, fill out the locus or calocus and give it to us and we'll review it. But if the providers aren't doing that, then we've got a potential mismatch between what we as carriers are required by law to do and what the providers are equipped to do. And particularly, I know the residential system is under incredible amounts of strain right now, just getting enough staff to keep the doors open. So I think it's important that we think through that issue carefully.
Thanks for that, Dan. And again, we're running out of time, so we'll go to Bennett, Melissa, and then Jennifer. And then if there are additional comments about this section, if you could provide those in writing, and we'll continue the conversation at the next RAC. So Bennett?
Yeah, this is probably lengthier than we can get into right now, but I know Interqual has developed with ASAM something called the ASAM criteria powered by Interqual. ASAM has its own thing called the ASAM continuum, and then you've got a manual process. I just want to flag, I could go into the weeds on this and we don't have time. I just think, I'm not sure that that's what the legislation intended, was that these commercial products be developing something that has some nods towards the nonprofit specialty groups. I'll just leave it at that because it's too complicated for right now.
Thanks, Bennett. Melissa?
Yeah, we went into detail in our last OIMHP, in our last written feedback that we submitted prior to the 5th RAC meeting, and just wanting to reiterate what we said, that we really are very concerned about outlier, the sort of statistical outlier management that we're seeing, where providers are being monitored in a statistical manner in terms of what codes they're billing and comparing them to each other, that we don't think that this is really what is in the bill, that the bill is advocating for monitoring for generally accepted standards of care based on clinical standards, not statistical standards. And some of the things we called out some of the practices by third-party company Change Healthcare that we're seeing, where they're sending out these they're calling them informational letters to providers who are supposedly billing 90837. There's a lot of contention around the use of psychotherapy code 90837, which is 60-minute office visit, more than their peers, and that these letters, we see them as intimidation, and not just intimidation, but as a way of actually changing provider billing practices, because they're intimidating. And if it's pretty much spelled out in the letter that, we're watching you, we're monitoring you, and if we continue to see these practices, we may contact you again, we may inform the insurer, and that in and of itself is going to tend to change people's practices. And this is really just based on statistics. And even if that Change Healthcare were to go in and monitor somebody and take a look at their, who's billing 90837 more than their peers, they're sort of looking for ad hoc explanations for why they're billing that code, rather than, just the fact that someone's billing a code more than a peer is not in of itself evidence that something fishy is going on. And so that's some of the problem with basing UR on statistics rather than on clinical standards. And we just want to make sure that DCBS is aware of that and is taking a really close look at that and how that, whether that fits into HB 3046, which we don't believe it does.
Thanks, Melissa. And Jennifer.
Thanks, and I'll try to be as quick as possible because I recognize we have 5 minutes. But I just want to reiterate, we did submit comments. We do strongly believe that the legislative intent of this bill was not to limit third-party vendors from clinical review processes, and we believe that the intent of this rule is to prevent homegrown criteria for a level of care decisions. But one thing in particular that I wanted to mention is that in some of the association comments, we're saying that WIT codifies the specific nonprofit criteria, and that is absolutely not true. And we actually call upon them to provide where it actually does do that if they're going to make that statement, because we're going to challenge that assumption and request that specific language. We strongly believe that we are permitted to continue the use of these third-party vendors who help us manage our clinical review in a way that we think is fair and suitable for our members and can control cost. So thank you for that.
This is not, so if I may reply, as one of the authors of this section, it is to preclude interqual from level of placement decisions. The legislative history is pretty clear on that. And so it is, as you look at the definitions and how that is, when it comes to level of placement, interqual cannot be used as a way around standardized instruments like the locus and CalLocus and the ACE, which is not the WIT decision. But if you look at the case, those are the instruments used in WIT for the judge to make the evaluation as to whether the plan was meeting that. The compromise was the ensuing paragraph, which was around medical necessity and other things. So it doesn't preclude from clinical review, but it does preclude from level of placement.
All right. Well, this has been a really productive conversation. I think there is some legislative history and the comments that the DFR team needs to look further into to really understand this Section 8. So we will go back and do that. I do want to take some time to offer anybody who's on the line, members of the public or interested parties, to provide comment. So are there any members of the public or any interested parties who would like to provide comment at this time? If so, if you could raise your hand. All right, seeing none. So next steps, our next RAC meeting is on March 10th from 9 to 10:30. I believe that the intent for that RAC meeting is to have a draft copy of the rule to discuss and also to continue these conversations that we weren't really fully able to dive into, such as this, clinical utilization review conversation. So is there anything else that we need to be adding to the agenda for that RAC meeting that I haven't mentioned so far? I think that'll be a lengthy conversation. So I look forward to seeing you all at the next RAC. And again, thank you very much for this conversation today. It was very helpful.
Thank you, Brooke.
Thank you.
Thank you, everyone.